Good afternoon, evening, morning, wherever you are. I think amongst this panel there's someone in just about every time zone. Welcome to this session, which follows on very nicely from the one that I think you've hopefully just joined, led by Shams, where in this session we're going to be looking at how partnerships have adapted their activities as a result of the COVID pandemic. So thinking about what they had intended to do and how that changed, and reflecting on that, but thinking forwards to changes that will be useful for the future. We've got four excellent speakers, one of whom has just lost his connection. So I'm going to, what we're going to do is we're going to have about 5 minutes of each speaking and then some discussion afterwards. So as people are speaking, please do put any questions you have into the question box. And if we have time, we will come to them during the discussion. I wonder if Britton is prepared to speak first instead of second, while we hopefully wait to Ben to be able to join again. So I will introduce you to Britton Gray. Britton is in America. She is the Executive Director of Global Partnerships and Global Work at one of the large American not-for-profit healthcare systems and oversees a number of health partnerships. And she's going to talk about some of the changes they've made through the pandemic. Thank you, Britton.
Thank you so much, Kit, and good morning, everyone. It's such a pleasure to be here with you. As Kit noted, my name is Britton Gray. I lead Global Domestic Immersion Programming at Providence. Providence is a U.S. not-for-profit Catholic healthcare system with 51 hospitals and over 1,000 clinics. And within our work, we're really driven by a belief that health is a human right. Building on that organizational heritage, we carry a commitment to solidarity beyond borders, and we partner with organizations in Guatemala, Mexico, Malawi, Uganda, and Nigeria. And as we seek to advance the decolonization of global health, as a system, we leverage the talents of our medical community in volunteer efforts to support this generation and the next of local healthcare workers. The mutually exacerbating catastrophes of COVID-19 have truly been devastating, but within the changing landscape, there have been opportunities to reframe partnership engagement. We've doubled down on maternal and child health, we've made new commitments to WASH, and we've tailored a layer of our strategy from patient care global volunteerism to instead deepening and growing capacity sharing initiatives. Technology is a key asset for this. I see technology as a nexus for digital innovation and compassion, and a vital tool for adapting and expanding the ways we support global health system strengthening. And so today I'm excited to share a little bit about the new virtual pathways for service that Providence seeks to utilize to strengthen clinicians who don't have access to continuing medical education or specialist consultation. We're motivated in this work by values of solidarity, of accompaniment, understanding that bidirectional transformation occurs through relationship and that power belongs to those on the ground. To illustrate the adaptations and growth that we have had within Providence and with our partners, I'll be sharing two examples, one from Guatemala and another from Nigeria. In Guatemala, we sponsor a maternal and child health program with Medical Teams International. In addition to community capacity building, the program strengthens the healthcare delivery system through trainings with Ministry of Health nurses and doctors. Within the pandemic, our in-person train the trainer model was threatened, but our partner and Providence staff spent a year redesigning the program to streamline it and also to use digital platforms to leverage mentorship from Providence volunteers virtually. So we have a new model, a 9-month maternal and child health certificate program that was approved by the Ministry of Health in our service region, and shown here in the photo are Ministry of Health staff members at a 2022 program overview. Within this work, Spanish-speaking U.S. clinicians mentor Guatemalan clinical trainers via Zoom, Team, and WhatsApp on key topics such as emergency obstetrics, integrated management of childhood illnesses, and monitoring and evaluation, while also fostering throughout that time dialogue regarding the soft skills that enhance team building for greater success. This is an example of a longer, thoughtful process of adaptation. We continue to examine with our partner how we can best evaluate its effectiveness and scalability. But what is certain is that COVID has given us a completely different way of thinking about supporting relationship connectivity and advancing capacity building goals in response to local assessments in new virtual ways. The second example from within our Providence work and partnerships is a partnership that it comes from Nigeria and is with World Telehealth Initiative. Medical Teams was an example of adapting an existing program, but this partnership represents forging a new partnership. Oh my, excuse me, I am trying to prevent my computer from restarting. We'll see how we do. This program represents responding to pandemic urgencies and strategy change. And so WTI connects medical expertise to vulnerable communities to build local capacity and strengthen delivery of core health services based on needs identified by the in-country partner. Through Teledoc health technology optimized for low resource, low bandwidth context, Providence physician volunteers work with Nigerian clinicians in the Opoji Kingdom to strengthen services in locations where extreme distance has separated community members from care. Through this telementorship model, we offer support for case analysis and specialty consultation to advance the knowledge and specialization of providers on the ground. About 88% of doctors in Nigeria, in the region where we work, seek employment abroad, in part due to lack of support for ongoing education. And so access to consult and education locally is specifically desired to reduce the exit of medical professionals. On the next slide, I have some voices from the field, insight into the full circle of impact of this partnership and work. From Dr. Akpele on the left, one of our Nigerian colleague leaders, we hear the power of solidarity and the value of continuing medical education and learning on the ground. From Dr. Bartlett on the right, one of our US physicians, we hear the profound connection and personal learning that comes from reciprocity and partnership. Although there's not time to read these extensively out loud, hopefully you'll be able to see their words and the power within. Like some of you, during the pandemic, Providence signed the Brochet Declaration on Ethical Short-Term Missions, and this has served as a beautiful point of reflection as we've connected with internal stakeholders about the balance of power within our work and about our ongoing call to build a future together where our US support is irrelevant. To make that future a reality, we strive now to support sustainable, strengthening efforts led by and benefiting local healthcare providers. The work described today in these brief minutes and these voices from the field represent growth in actualizing what we view as our ethical call. I'll pass it back to you, Kit.
Thank you. Thank you very much, Britton, and particularly great to hear about work in South America, which is an area that FET, our organisation, doesn't work in. So wonderful to hear that. Thank you very much, and we'll come back to you for some questions afterwards. Charmin, are you able to speak next? We're still missing Ben Bwele, unfortunately. So Charmin's unmuted. I'll take that as a yes. Thank you. So Charmin is a midwife in Bangladesh. She has nearly 20 years experience of work and development projects, and she's currently project manager for a twinning partnership between the Bangladesh Midwifery Society and the Royal College of Midwives in the UK. So Charmin, please tell us about your work and the adaptation through COVID.
Thank you, Kate. Hope you are hearing me. Kate, there is a small correction. I'm not a midwife. I have been working from 19 years in the development sector of Bangladesh. Last year we have implemented the TED COVID response project, which was designed and implemented during the pandemic. So face-to-face travel between UK and Bangladesh was never planned as a part of that project. However, it is important to recognize that this project was a part of 5-year partnership, which is where I am working, the twinning partnership between Bangladesh Midwifery Society and Royal College of Midwives, funded by UNFPA. This partnership was established with face-to-face contact. This, after the pandemic, this changed dramatically during because of all visits have stopped. We had hoped to do more in-country travel during the project and to be able to deliver training face-to-face, but that was not possible. We experienced delays in procurement resulting from closure of shops and difficulties in purchasing. Also, we faced difficulties in distributing the materials. However, working with an agent, we managed to procure and distribute all necessary equipment and supplies. Before the pandemic, actually, BMS Bangladesh Midwifery Society has 4,407 members, midwife members. We were struggling to accommodate them for meetings, and our midwife executives are working remotely all over the country. So it was difficult for us to have face-to-face meetings from the beginning of the project, and we were looking for ways to do this. And midwives also need government orders to come over for any meeting, face-to-face meeting. So during the pandemic, the technology was embraced to enable remote working. For continued partnership with RCM staff, volunteer midwives, continued functioning of the professional association with engagement of board and general members, continued delivery of the funded projects through remote connection of the project team in country and connection between the project team and the participating rural health centers. 5 rural health centers where we implemented the project to deepen engagement with midwives who continued to work during the pandemic, especially those 5 rural health centers. These technologies where BMS has a website, embedded database, e-learning platform, membership system. We already had a system to get membership payments through Bkash, so that was so helpful. BMS already implemented a e-voting system, which was implemented during the pandemic also. BMS opened a Zoom account to enable large meetings without any time limit. This was used for the project team to connect, but also for UK midwives to support remote leadership skills development through online training and mentorship. Was also used to connect to general members and share information about the project. We use our Facebook Messenger groups for information dissemination, Skype messaging and call, Google Meet, online training where safe abortion services, post-abortion care and family planning. Feedback from participating midwives was that more face-to-face training in clinical skills would have been beneficial. There was also a telephone helpline system during COVID. Midwives and also when the situation permitted, BMS management paid visit to 2 Upazila health centers based in Dhaka to establish a connection, visibility, and maintain relationships with the respective UHCs, personnel and project team. We could promote this through the Facebook so that other midwives across the country could see what was happening. Over the last 5 years of the partnership with RCM, we have developed 50 young midwife leaders and have offered some internship opportunities. One such YML stepped into the project leadership of this TED project and did a great job. She became the general member when we had the election in 2021. She has become the general secretary of BMS. Currently, she's working with us. So thank you. Thank you, Kate.
Thank you very much, Charmin. And just a snapshot of huge changes that have obviously taken place in your work as they have in so many others. sadly, we had Ben for a moment there, but I think he's gone again. And so I'm going to turn to, oh, Ben's back. Ben's there. Ben, are you able to, we hope you'll be able to stay long enough this time to be able to speak to us. Ben is in Tanzania. He is an epidemiologist and clinical researcher at the University of Dar es Salaam, and he works as part of a partnership with University College Hospital, London. Ben, over to you. Thank you.
Right. Thank you so much. Really, I would like to give magnificent, sincere gratitude to THET for actually giving us an opportunity to fund our project that was running in collaboration with the University College London. Well, the project was designed mainly to address maternal and newborn health, particularly focusing on obstetric hemorrhage. And you know, the main idea was relying on the fact that in Tanzania, maternal mortality rate was, I would say, labeled to be one of the most sub-Saharan countries with high maternal mortality rates. And we talk about 556 women dying out of 100 live births. And that was something that created a hot discussion at the national and the regional levels. Now, looking in the region of Mbeya, actually, the situation was catastrophic, where we had about 766. So we're talking about 25% more death in Mbeya region. So we did a situation analysis in one tertiary zonal referral hospital, and we found that obstetric hemorrhage was an issue. And so we wrote this particular application to THET, and then we start implementing this face-to-face, which was combined with actually physical training program in Mbeya. And what we thought that experts from London will be able to train healthcare workers in Mbeya in tackling obstetric hemorrhage, but also at some point they would be in a position to travel to Mbeya to give some sort of a physical face-to-face training. But you know, COVID came in, and actually in the beginning of project kickoff, we experienced massive restrictions in traveling, and most of the experts that we wanted them to come to Mbeya to train, they were not being able to do so. An expert at a zonal tertiary referral hospital who we thought they should travel to UK to receive some sort of mentorship, they could not do so. And you know what happened? It created some sort of frustration on how best we could run this particular project. And so what we thought now quickly, we had to to develop some sort of a mitigation strategy. So we wrote that some sort of an amendment to THET, and they give us an opportunity to address these particular challenges in the mid of the implementation of the program. And what we did, actually, we created a WhatsApp group, because the project basically was designed to be multidisciplinary training in obstetric, hematology, ultrasonography, as well as anesthesiologists. So what we did, we created four groups. And in creating these particular 4 groups, we noticed that these experts at the Mbeya Zonal Referral Hospital, they can communicate directly to experts in the London team, to the London team. And so we had a total of 4 WhatsApp group, and these people, they created some sort of Zoom meeting so that they can get some sort of online mentorship. And so to say, we had to continue conducting this particular project in Mbeya, where the online session had to proceed as they were planned before. But the physical session were supposed to now to be implemented by the local expert. And the local expert now created some sort of lecture or some sort of pre-recorded video, which we uploaded them in the website, which we called it the London Mbeya models of the video training. So this is an example of an anesthesiologist at Mbeya Zonal Referral Hospital who was giving this particular lecture through a pre-recorded video in one of the facilities. Now we had a total of 4 facilities. So having 4 facilities, we had an extra 8 local experts who were receiving expert training from the London to make sure that the physical training, as well as other missed sessions that were not well packed during the online session, could be well covered. So can you go to the next slide, please? Right, so this is an example of where the experts were available on the physical face-to-face models. You could see the expert in their masks. Now we wanted really to maintain the distance, the epidemiological, prevention of diseases with high transmission rate, but we couldn't do so, according to the situation, talking about the real life situation and infrastructure, we couldn't address those, but at least the use of infection prevention control, as well as the use of masks were addressed. Can we go to the next slide, please? Yes, in another scenario, we were actually urged by the government that all types of gatherings have to be considered prohibited until stated otherwise. So the lucky part was that during the design of the project, we were working in partnership with the regional authority representative of the Ministry of Health. Therefore, they could give us an opportunity to do so, but with some sort of reservation. You could see now there is only one chair in the front of the simulation models where one person would enter into a room to get examined, to get scored, and whatsoever to evaluate the capacity or competences. Can you go to the next slide, please? Right. And so these were actually the impacts that we achieved at the end of the project. We could see the hematology proportional change was actually from 52 to 78. In sonographical skills, it changed from 31% to 66. And surgical skills changed from 61 to 84. Obstetrics, which actually covered most of our online session and face-to-face session, give an impact of almost a 50% increment. And so, the design of this particular project, we were really targeting reaching out above 95%, end line score, but we don't know why we ended up in this particular pattern. Some people, they were saying, oh, Dr. Ben, you have done a lot. And the participants themselves, they were appreciating, but we think and we felt that COVID created some sort of the technical skills change barrier. Can you go to the next slide? Right. So talking about improvising. So this was an example of the session that was live. I'm sorry that you cannot see a screen. There was a screen on the other side. I am the one who appeared to hold the mic there. And the team were actually listening to the two local facilitator. And there was a screen on my left side there for a facilitator in the UK trying to chip in whenever the discussion was coming up or whenever there was some sort of information that was needed. It was pity, again, that Tanzania faced a dramatical sort of exceptional presentation. You could see one of the experts is on mask and another expert is not on the mask. And one will raise a question, what was happening in this particular country? Well, in 2020, I would say, we passed through government some sort of ambiguity on the way we control the COVID-19. So, some sort of the epidemiological method to control the disease came in on board in the mid of 2021. And so in some time, I would say in the mid of 2020, there was a little bit of a confusion on how should we control the disease. There were even thought that people should just go for prayer and they should not wear masks to fight the disease whatsoever. So we had our own issue on the other side, but at the end of the day, the technical and the scientific merits of preventing the disease, mitigating the disease, and at the same time also making sure that we address this were on board. Next slide, please. And so to say, this particular project, at the moment, it has created some sort of a talk in the region at the office of the regional medical officer. They think that we have done a lot, but in fact, most of the, if it was a football team, the midfielder of the team was someone known as Jessica. Yes, Jessica, who was actually the program officer of THET, who actually was ready to give us a little bit of flexibility. And the team was resilient to the point that actually we managed to end up to the end of the particular project. Many thanks actually to the project officer, coordinators for Tropical Health Education Trust, as well as the expert from the University College London, who made this particular project go into successful. Thank you so much. Right.
Thank you, Ben. Wonderful, and you're very kind. It's quite obvious from your talk that the vast majority of the flexibility has been at your end. And my goodness, in the UK, don't we know a bit about government ambiguity on how to manage COVID-19? We will come back to you for some discussions. Really interesting to see the impressive results, even on very practical skills there with your hybrid system.
Thank you so much.
I'm going to move now to Ingvild. So we've been around the world. We've been west, east, south. We're coming to sort of north central. Ingvild is in Norway. She is a practice development nurse, a neonatal nurse with the Global Health Directorate of Oslo University Hospital. And she's going to talk to us about their partnership work with a number of countries, including some in Africa and India. Thank you, Ingvild.
Thank you, Kits. Oslo University Hospital have several ongoing global health projects with partners in India, Ethiopia, and Malawi. Our main goal is to build competence centers and educate health personnel. Sorry, is there something wrong with the sound?
Echo. Do you have two devices on at all?
Sorry?
We can hear a terrible echo. Do you have, by any chance, have two computers connected? I think that might be better, much better.
Thank you, Kits. So I'll start over again. Oslo University Hospital have several ongoing global health projects with partners in India, Ethiopia, and Malawi. And our main goal is to build competence centers and educate health personnels. Our main method is exchange of health personnel, because we believe that by empowering individuals, institutional changes will occur over time. We build our partnership on reciprocity because we also believe that we can mutually learn from each other, both us in the south and our partners in the north. And we have seen significant changes over time, both related to clinical skills, and we've seen staff being empowered. And we really believe on this method of exchange. But then in 2020, when COVID occurs, we are forced to think differently. And we have to stop the exchange. And we're sending all our nurses and physicians back to their home institutions. And us in the administrations are buried in the worries of keeping our projects alive, because everything we've done is built on the exchange. Our funders, NOREC, challenge us to move over in a more virtual way of collaborating to ensure sustainability of the results that we have reached. We start reviewing all our activities in our project, and we gather our partners and former participants has been on exchange, and we review all the activities we've had, and we figure out that yes, even though we cannot work bedside together clinically, we can continue collaborating. For instance, we've had these 2 years, we've had focus group meetings online with health workers from both partners, where they discuss clinical issues that they experience in the clinic. We've continued with our education program online with weekly meetings with students. We've arranged seminars to learn from each other, and we have established a theoretical online platform to gain theoretical knowledge. We have also initiated new ways of collaborating. We've initiated a writing group to focus on research in the partnership, and we have initiated a training program within leadership and management. So yes, we have been able to turn our exchange project into a virtual competence building program. However, we have during these 2 years have had a goal to go back to exchange once we are allowed to do so, and hopefully we can do that within the end of this year, or maybe early next year. However, there are a lot of things we've learned through these 2 years. For instance, we haven't had any online communications with our partners earlier, but now during these 2 years, we built up an online platform where we can communicate weekly and track our goals more frequently than we used to do. We've also been able to use former participants in our online sessions, which has been new. However, there are a lot of challenges we've also met due to COVID. For instance, we've noticed that us and our partners have a different impact of COVID. For instance, India in the second wave of COVID, they really challenged, and almost everyone was infected by COVID and no one were able to go to work. And in times as this, it's not time for having a focus group meeting discussing how to improve the clinical practice. So in these cases, we were able to continue our meeting places. We were not talking about improvement. We were talking about how we can support each other as partners and how we can be a fellow nurse or a fellow physicians and support each other in what we're standing in. So there's a lot of things we've gained through this online 2 years, but we're also very looking forward to bringing the online competences we've gained into also bringing exchange on board again. Yes, thank you.
Thank you very much, Ingvild. Really lovely to hear about that, the example of the support that you've been able to show each other because of those connections. And I think we will all recognise also the desire to at least some extent go back to actually meeting people that we've only seen on screen like today. We have only a very short time left, so not much time for discussion. What I'm going to do is turn to you each in turn with one question. We'll see how we get on with one question. I'll go back to, we'll go in the order that you've spoken so that those who spoke last have a bit of a break. But just to ask you really, of the adaptations that you've had to make, what do you want to take forwards for the future? What are the useful things to take forwards from the adaptations you've made through COVID? So I'll come to Britton first to ask you that.
Thank you, Kit. And thinking about adaptations we want to keep for the future, I think we really see a dual future from here that encompasses virtual as a baseline assumption and travel where possible and most meaningful, but not the assumed priority if and when our partners have broadband connectivity. So not only are we keeping a focus on digital pathways for service volunteerism, but we seek to expand them. And as a part of expanding, I hope that that's going to open new doors for other types of capacity building, such as at the level of healthcare administration, thinking about finance, HR, supply chain, other formidable aspects of healthcare delivery that are so vital to effective and sustainable care.
Brilliant. Thank you, Britton. And yes, we at THET are thinking very much about less travel and how that impacts our carbon footprint positively. Charmin, tell us about what you would like to take forward in terms of adaptations. You're on mute still, Charmin.
Sorry. I would like to say that the project BMS has implemented with RCM, it was very helpful because if midwives can provide the MR, safe abortion care, that will help the women to get access to these services, because rural women don't have this kind of services. They don't get these services easily. So I would like if BMS can raise fund and do this also in other Upazila sub-centers, and also the technologies we used, we can continue the technologies to enable remote connection and community with BMS members, project teams, board members, and UK partners. Also, the technology is very supportive for communicating with the in-country national partners also, because in that case, if we can reduce the number of meetings, then it is environment friendly and also cost effective for us. We can continue and develop new partnership to ensure BMS ability to harness more innovation potentially with the technology sector as way to address digital poverty for young women in Bangladesh. Thank you, Kit.
Thank you, Charmin. And a really good point there, that the virtual methods of communication, and someone's made this in the chat previously, are only as good as the connections to those who need them. So that needs work, doesn't it? Bernard, what would you like to carry forwards from what's happened?
Right. Actually, it has been our first time to use technology to connect to partners all over the globe, particularly starting from UK. And we have learned that we can expand the program by using the digital method. And we were thinking actually to come up with another version of this particular program, where this particular moment, we use screen computers and monitors, big screen for people to stay in the class, some sort of simulation, face-to-face and online session. But we think we can go a little bit further using the mobile phone, that the modules that we have trained, they can go further, making sure that these people, they can access these particular materials at home. With this particular project, we were using live online session and pre-recorded session by local experts. So we think that we can make all of this particular session digitalized in the mobile phones, and we can scale up the use of this particular platform. It was an interesting phenomenon for sure to have an expert of ultrasound teaching our midwives on how best to read reports of ultrasound in Tanzania. Now we think that we can make that particular knowledge available in the digital platform, particular mobile phones, and we can scale up this particular project nationwide, maybe in other African countries, particularly in Sub-Sahara. They can learn from this particular innovation. Thank you so much.
Thank you, Ben. And yes, so scale up being next on the agenda for the successful projects. And last but not least, Ingvild, something to take forward.
Yeah, I think it's a lot of similarities, but I think even though we want to focus on exchange from now off, I do think our virtual channels can help us to be better at follow-up and preparations for what we want to achieve with our partners, and especially follow-up participant that's on exchange from both partners. I think that's the main thing we will get out from this. Yeah.
Fantastic. Thank you so much, everyone. Delighted that we managed to get all four of you on stage in the end, and we've heard examples of digital transitions, of hybrid working, of a shift in the sorts of support and exchange that's taking place, and things to take forward from that, including thinking very carefully about how and when to use that physical interaction that we all need, and when better to use virtual means. I'm going to close this session now with huge thanks to all of you who've joined us and all of you who've listened. And as the session ends, I'm just going to introduce you to finishing with a short clip from the WHO's most recent video on compassion in healthcare, which brings us back to the quality themes of the previous session. So thank you very much, everyone.
Thank you.
We treat our guests like humans, not a pathology. They're welcomed with a pot of tea. Their rooms are bright and comfy. 80% of the support staff are former addicts. They understand shame and despair because they've been there. Patients know they care, and outcomes are beyond compare.
I was caring for a young mom with many an affliction: mental health, sexual abuse, drug addiction. She needed a lot of care, but was rejected everywhere. The addiction unit refused to help because of her mental health. The psychiatric unit wouldn't take an addict. So her options were restricted because the agencies weren't communicating. These silos are really frustrating. I brought the agencies together to see whether we could work better to serve these patients and sow the seeds of stronger relations between our organizations. We embarked on a process of co-creation which led to several innovations, like sharing our learning and training, broadening our vision and building trust. The big shift in quality came with the decision to switch to a common policy.
We are patient advocates.
I lost my daughter because they diagnosed her brain tumor as epilepsy.
Our baby boy was brain damaged because they didn't check for kernicterus when he had jaundice.
The medical profession is frightened to partner with patients who've been harmed. They're scared of being exposed. They get alarmed.
I wanted to get everyone at the table. They said I was ignorant and unstable, but I persisted, and now, because of me, there's a patient on every ethical committee right across the country.
We changed the standard of care. We wouldn't let it rest until the guidelines on jaundice said they have to test.
As parents, our desire is to make sure that these things are never repeated.
We burn like fire and won't be defeated.
We're not just patients. We're change agents.
When you see a baby not getting optimal care, it's really hard to bear. Their clothes often soiled and smelling, some with IV swelling. Sometimes there's 15 babies and only one nurse in ICU. How much can one nurse do? We're in a public hospital catering for the poor, and all the parents were outside the door. They'd grab my arm.
Doctor, no one talks to me. How is my baby?
They're suffering stress and separation anxiety. One day, I had an idea. We're so desperately short-staffed. Would it be so daft to draft these women to help their babies in ICU? The nurses were bemused by this new direction.
You can't expose preterms to germs and infection. The mothers will get in our way.
I thought that's what they'd say, but I pushed it through, and we had to train them in what to do, how to wash their hands, how to put on protection, keep everything clean. But the mothers were so keen, even changing a nappy made them happy. A mother's dedication is a powerful medication. We can learn so much from mums, because love impacts outcomes. They would instantly report anything wrong, and it wasn't long before the results began to show. All that physical contact made the baby strong. It started as an HR solution, but it's turned into a revolution. There's been a ripple effect that I didn't expect. The mothers have gained confidence and self-respect. They have new skills, which is empowering. I see uneducated women flowering. And what they've learned will spread to the future and beyond the home to their daughters and friends having babies of their own. And for the nurses, as they're released from tasks that require less skill, they can focus more on babies that are ill. Some people think that family-centered care is about passive participation. But for me, it's about transformation.